It is my distinct honor to introduce today's speaker, Dr. Deborah Levine. Dr. Levine is a professor of medicine at Stanford University in the Division of Pulmonary, Allergy, and Critical Care Medicine, and a key leader in the Stanford Lung Transplant Program, where she directs transplant outreach. Before joining Stanford, she served as the Rowan Witt Endowed Professor at UT Health San Antonio, where she led both the Lung Transplant Program and Pulmonary Hypertension Center. Dr. Levine completed her medical degree, residency, and pulmonary fellowship at the University of Arizona,
Hi, Debbie.
Followed by specialized training in critical care, lung transplantation, and interventional pulmonary at UT Health San Antonio.
Calling in from Copenhagen.
Hi.
Dr. Levine is internationally renowned in both the pulmonary hypertension and lung transplant communities. She serves on the board of directors at CHEST, chairs their Council of Networks and the Pulmonary Hypertension Interstitial Lung Disease Guideline Working Group, and previously served as president and chair of the 14th International Congress on Lung Transplantation in Paris. She has played major roles in national and international guideline committees that continue to shape the way we care for our patients today. Dr. Levine served as co-editor of Lung Transplantation and Pulmonary Hypertension and completed a distinguished tenure as editor-in-chief of Advances in Pulmonary Hypertension. She remains a national leader through her ongoing work with Pulmonary Hypertension Association, whose partnership has helped make today's lecture possible. Dr. Levine has been a principal investigator on numerous multi-center trials and has published and presented extensively. Beyond these remarkable achievements, she is deeply committed to collaborative, patient-centered care and is widely known as a generous teacher, mentor, and colleague. Please join me in welcoming Dr. Deborah Levine. Over to you, Debbie.
Oh, thanks. Am I on mute? Am I on mute?
We hear you.
You hear me? Okay, great. Well, thank you so much for the introduction. It's a great way to start the day and very, it makes me feel very good. So thank you so much. And I'm so happy to be here. And you know, I had a really great time last time we did this a couple years ago. Lots of good questions, lots of interactions, and super excited for more of that the same today. So I'm going to try to get through this so we have enough time to go through questions and discussions and start, you know, build up your questions if you want in the chat, or if you have a burning question, you can just yell it out. It's okay. And I have no financial disclosure. So one step back is that this whole lecture, but the whole lecture series, nothing like this could be possible without Barb and Trish, and also and their work with the PHA. The PHA, if you are not a member, you don't know about PHA, it is absolutely the most incredible association. As you go forward into your careers, you'll probably all want to be part of something. And let me tell you, this is the one. It really includes and encompasses not only us as clinicians, but caregivers, patients, families, industry, scientists. It is such a wonderful organization that really is all about education, educating everybody from us all the way to the patient, to the patient's family. And so please consider joining. It's very non-expensive. And with your, when you do join, you have the wealth of multiple online education. You have multiple ways of learning. So please look at www.phassociation.org. It's a great place to be. So let's get started with our lecture for today. So let's say you're in clinic. You could be in medicine clinic. You could be in pulmonary clinic or even cardiology clinic. You're just in clinic, and your associate or your nurse comes by and says, hey, I have two patients coming in with dyspnea. One's in room 1 and one's in room 2, and they both have echoes. So patient 1 and patient 2 are in different rooms. And patient number 1 is a 57-year-old lady who has a history of hypertension, diabetes, CKD, AFib, all of kind of the metabolic pictures that you can see in one person. But she also has short of breath. And then you go next door before really seeing Mrs. Number 1, and Mrs. Number 2 also short of breath and really has comorbidities, still hypertension, but she also has chronic kidney disease and then systemic sclerosis, so scleroderma type disease pattern. So, the question is, in the little, slips, you probably don't have that anymore because it's all electronic. But usually when you used to see a patient, you used to have some information about the patient before. And both of these patients had an echo in that little slip when you went to see them. So you thought, okay, I'm going to see 2 patients with pulmonary hypertension. So you already have that kind of going for you. And you want to see, do I just treat patient number 1 and diagnose patient number 2 the same way? Well, let's see. Patient number 1 has a WHO or an NYHA class 3 scale of dyspnea. So that means she gets short of breath with just minimal walking or mainly daily activities. Her blood pressure is elevated. She has an increased JVP. She's irregular. She has AFib. She's in it right now. She has a loud P2, and she also has a murmur, a 2 out of 6 murmur. She also has some lower extremity edema. So put that in your back pocket and move on to number 2. In door number 2, Mrs. Number 2 also has class 3 symptoms, but she has kind of a normal-ish, maybe mildly elevated blood pressure with an increased JVP. She is not an AFib. She's regular. She also has a loud P2, and she also has a murmur, almost the same type of murmur, and she also has edema. So right now, they're looking pretty similar. What do we do? Do we just say, okay, you both have pulmonary hypertension. It says it on the echo. Thank you and goodbye. You're going to cardiology. You don't have to answer that. You can tell me at the end. So when you talk about pulmonary hypertension, I don't know if you can see me, but pulmonary hypertension itself is like an umbrella term. There was a recent World Symposium on pH just a year and a half ago, the 7th World Symposium on Pulmonary Hypertension. And what they do is they classify pulmonary hypertension clinically and how patients are similar clinically, how we treat them and diagnostically. So this kind of classification system has been kind of evolving over many, many years, and this is the most recent iteration. So 5 groups of pulmonary hypertension under this umbrella: PAH, which we're going to be talking about most today, pulmonary arterial hypertension. Group 2 is pulmonary hypertension associated with left heart disease. So for the cardiologist or budding cardiologists in the whole room, which I can't see, but and then group 3 for all of us pulmonologists, that kind of pulmonary hypertension that's associated with either lung disease or hypoxemia. Group 4, have you ever heard of chronic thromboembolic pH or CTEPH? Well, there's a whole group associated with pulmonary artery obstructions, and that group of CTEPH patients takes the majority of those patients. Although there are other pulmonary artery obstructions like sarcomas that can be involved in this group as well. And then there's a group that kind of ebbs and flows over time in different iterations, and it's called pH with unclear or multifactorial mechanisms, and that has to do with all of these things you see here. And we'll talk a little bit about them, but mainly focus on the others. Besides a clinical and diagnostic kind of classification that we just saw, groups 1 through 5, there's also kind of a hemodynamic classification, and that's really figuring out or defining where the lesion is so that you kind of know how to treat. So not only are you putting patients where they fit clinically, but also hemodynamically. So this is a schematic of a kind of the right heart circulation going all the way from the right atrium all the way through to the aorta. And remember, the pulmonary capillaries where things all happen. So as patients are when you're looking at patients who are having more of a precapillary issue, and that's before the capillary. These are patients that really don't have an increased wedge. They're more of a, it's more of a affecting the actual vascular tree. Patients who have heart disease and other types of reasons to have a high wedge are mainly post-capillary pulmonary hypertension. And allow me to go to the next slide, and I'll show you this a little bit better. This slide's pretty neat because it kind of puts everything together. Your definition of what we just talked about, the characteristics of what you would see on a right heart catheterization, and then what one of those clinical groups 1 through 5 fits through that. So pH is defined as a mean PAP greater than 20 on right heart cath. You need a right heart cath to get that diagnosis. Once you have that, you know at least that you have pulmonary hypertension. But then you have to dig a little deeper to see if it's precapillary, postcapillary, or combined. So if a patient has a mean PAP greater than 20, but their wedge is normal and less than 15, and their PVR is greater than 2 Wood units, then you really fit group 1, group 3, which is hypoxemic or lung disease, group 4, CTEPH, and some of group 5. Isolated patients who have just postcapillary pulmonary hypertension, that means they meet criteria for pH, mean PAP greater than 20, wedge now elevated, and PVR normal, less than 2. Those patients really are the really tried and true group 2s and some of group 5. And then you do have patients with combined pre and post capillary pulmonary hypertension, which we can talk about in the discussion if we have time. And then exercise pH, this came back after being out of the definition for a while, and we can talk about that as well in the discussion. So we're going to go through a few lessons. And the first lesson is pulmonary hypertension, and I'm talking about now that umbrella term, pH. It's pretty common. About 1% of patients all over the world, over than 60, have pulmonary hypertension. And so it's not uncommon to see it. The most common type of pulmonary hypertension, believe it or not, isn't the main one we're going to talk about today. It's those with patients who have heart disease or group 2 PH. This is a very old study from probably 10, 15 years ago, but it still shows us, we still know throughout studies done after that and knowing in clinical practice that this is the most common type of pulmonary hypertension worldwide. Group 1 PAH, the one that we talked about first, where the patient has a normal wedge pressure and an increase in pulmonary vascular resistance. One of the major groups is group 1. And group 1 is rare, but is probably the worst and most deadly to have. And so you want to make sure you understand what it is and try to remember to have a low threshold for diagnosis. And it's rare. So this is in a group of people, it may be very difficult to find, but you can find them. When you talk about pulmonary arterial hypertension, you have to look at what's really happening. And this is a nice schematic looking at symptoms, looking at hemodynamics, and looking at where patients are in terms of the progression of the disease. So when patients are diagnosed, or even before patients are diagnosed with PAH, their cardiac output is stable. They feel good. They have the ability to do what they want to do in most cases. But in the background, the pulmonary arterial pressure as well as the PVR, pulmonary vascular resistance, are increasing. You may not even know the patient has anything wrong with them. They start becoming symptomatic at a point where the cardiac output is starting to decline, and they may start getting short of breath during activity or even as it progresses further down the line. In the meantime, that mean PAP is going up, and the pulmonary vascular resistance is also going up, such that as it progresses, that cardiac output falls, and this is what patients are dying from. If they are worsening and decompensating, it's from right heart dysfunction and right heart failure. So lesson 3, What are the clinical clues, sorry, in the dyspneic patient? Because patients can be dyspneic for a number of reasons, right? It's not all going to be pH. So Mrs. Number 1 and Mrs. Number 2 are dyspneic, but we have to find out, why do we think, if they didn't have an echo, are they dyspneic? So really, it could be an idea that you're thinking, keep it in your mind in every patient you're working up for shortness of breath. Some of the clinical signs in patients with PH that you might look for are loud heart sounds, or even increased and I'm so sorry, clinical signs, not just symptoms. You're looking this on physical exam, and we'll do symptoms next. Really on signs, looking for any kind of cyanosis. You're thinking maybe the patient may have a congenital heart disease. They may have PH secondary to that. You may have a third heart sound. And that systolic murmur that we saw in both patient number 1 and number 2 could be there. You know, when you talk about thinking about a patient with PH, and if the patient has even PAH, you want to know why, because it's not very common that you can't figure it out, but you have to go through kind of all of the diagnostic or associated diagnoses to say, does this patient have PH or PAH secondary to a reason, or is it idiopathic, which 50% of patients with PAH are idiopathic. So if a patient has clubbing, usually patients with PAH do not have clubbing, but if they have congenital heart disease, or if they have bronchiectasis or some kind of ILD along with it, you may think they're in group 3 or sometimes group 4. Pulmonary patients with pulmonary veno-occlusive disease or liver disease also have it. Patients who have PDAs or Eisenmenger's congenital heart may have it. If patients have heart-lung disease and they have crackles, usually with patients with just plain old PAH, they don't have a lot of changes on their lung exam. But if they do, you want to consider group 3 patients. Patients with telangiectasias, maybe they have HHT or maybe have scleroderma. And look for patients with other things that could be related to things like connective tissue disease. That might be patients who have early PH, but then you want to think all the way down to RV failure. These patients also have things that you want to look at. Patients who are already having peripheral edema or ascites. You may think they're already in right heart failure. In terms of symptoms, they're non-specific. You're not going to pick one thing and say that patient has PAH. Dyspnea is the most common, and dyspnea on exertion is the most early presenting symptom that a patient may have with PAH. All of these others continue on the progression of disease, but the very first and probably most common is dyspnea and then fatigue. Syncope, chest pain, palpitations, and edema, you're getting a little bit farther on in terms of considering whether the patient has right heart failure. You want to know, well, could this patient have PAH? And you think about risk factors. So is the patient have hereditary PAH? And so you think about family history, patients with connective tissue disease, those with Eisenmenger syndrome, patients with liver disease. Did they have one of the environmental drugs? Do they do some types of drugs that may be associated with PAH? And then very few, but some patients with HIV, I think 0.5% of patients with HIV may also have PAH. So is there a reason to suspect when you're doing common studies like an EKG? Well, patients with right axis deviation and right ventricular strain may have some severe PH, but those with right atrial enlargement and right ventricular hypertrophy also may be leaning towards PAH. Now, remember, you can have, and most patients are, normal EKGs or ECGs if a patient is just being diagnosed. So don't think you have to have changes on the EKG, but these are associated with them. Same with the chest X-ray. You know, when we read chest X-rays, we aren't looking so much at laterals anymore. I mean, in the clinic, you might. We do in PH clinic, but remember, the pulmonary arteries are this kind of tree trunk type of structures coming out of the mediastinum, right and left. And on the lateral, you usually see this retrosternal blank space or dead space. There's just air there. That's the right ventricle and saying everything's fine. With severe PAH, you want to look at really enlarged PAs, both sides. You kind of lose that ski slope of the aortopulmonary window because it's filled up with the PA. And you may also see this fill up, and that's your RV being enlarged. So these are some signs of things that could be with advanced PH, but remember, most of your patients are not going to have these signs until they get a little bit more advanced. On the echo, is there a reason? Well, someone got an echo on Mrs. 1 and Mrs. 2 and send them to you. So we know that some signs are there that you want to suspect PAH, and that's more the morphology of the chambers. So your RV and RA may be enlarged. You may have an effusion. You may have kind of that change of the septum. It's usually a little bit curvilinear into the left ventricle that kind of straightens out. The IVC does not collapse as well, and you may have a decreased RV dysfunction with some signs like TAPSE that we can go through it as well at the end of the talk. So one thing when you're looking at patients, if you're trying to evaluate PAH or group 1 PH, or really any of the others, you never want to miss group 4. Now, why did I skip all the way to group 4? It's because within the evaluation for pH, you usually get a VQ scan or a ventilation perfusion scan. And the reason you want to get that on every patient is because this type of disease is actually curable with two different types of treatments. Patients can undergo thromboendarterectomy at a CTEF program where they kind of pull out the clots during cardiac during surgery, and then they also can do balloon pulmonary angioplasty at some centers. So the biggest problem is we miss it is because we don't think about it. So every patient that you're thinking about PAH, think about CTEF, get the VQ scan. You can effectively rule it out with this. Remember, acute PEs don't always completely resolve. And I think a lot of centers are really developing PE centers or PERT centers to look at these patients after to make sure that coming a month or two later, or even several months to a year later, that there's not a patient that's having increasing shortness of breath over time, and then you can actually see that they may have developed CTEP. And we'll go through that a little bit more. And this is just a picture of a patient with pulmonary arterial hypertension and those with CTEP. You can definitely see this kind of moth-eaten type of place where the ventilation is going, but the perfusion isn't because it's blocked by that, blockage. So basically, VQs can help us a lot with the pattern. It's kind of a pattern of what the nuclear med radiologist sees. Other things you want to know about patients who may be at risk is if the patient has a family member who's had a mutation in the past or has familial PAH. Much of hereditary PAH is related to different genetic mutations, BMPR2 being the most common, but also patients who don't have family history still can have a BMPR2 mutation. Patients with, I'm going to say, almost all connective tissue disease or autoimmune disease can lead to PAH, but scleroderma is the most common. In fact, in the American Association of Rheumatology, they actually request a yearly echo for those patients to evaluate if a patient may be developing. We talked a little bit about HIV, portal pulmonary hypertension. If a patient has portal hypertension or even just liver disease, these patients can develop portal pulmonary hypertension, which is important to recognize and treat in an expert center. Congenital heart disease, we talked about that as well. So diagnostic algorithm for pH. I think, I'm not sure how many pH specialists, I know there's one pH specialist out there because he already said hello to us, but those who are pH specialists and those who are either cardiology or pulmonologists who take care of pH patients in their practice, really the algorithm is often similar. I think the big question is at some point it is nice to have an expert either at a pH specialty center, a PHCC or one like it, so that the workup can be complete and next steps can be carried through. So really, the evaluation is to establish the diagnosis. Is it PAH or is it one of the others? Confirm the diagnosis only by right heart cath, classify the type of PH with your workup, and then also determine the disease severity and how would you select the therapy. This is a very nice, you're gonna get all these slides from PHA. These are PHA's beautiful slides, but this is a very nice diagnostic algorithm within the World Symposium PH meeting. And really, the thing is to really kind of identify patients who may have risk or may have signs of PAH. Then you start with some simple non-invasive tests that everyone can do to kind of know where you're going. And based on that, you can either say they probably don't have PH or they do, but maybe we will check an echocardiogram. And based on that, you kind of go through the algorithm saying, okay, the patient may have pH based on the echo, but what type do they have? And this may be a good time, depending on how sick the patient is, to have them seen at a PAH or CTEPH center, because at that point, they'll probably want to get a right heart cath. They'll want to make sure they get the VQ scan to rule out CTEPH, and then they'll want to do a comprehensive evaluation for what therapies to do. Okay. Okay, so is that all you need, is a echocardiogram that says the patient has an elevated right ventricular systolic pressure or a pulmonary arterial systolic pressure? No, on echocardiogram, I think there's a vast a mountain of more information that you can get from the echo, and more is being evaluated all the time. And many of these studies, many of these kind of tests or assessments from the echo are beyond the scope of our talk today, but very interesting of how the echo is turning into a really good study for more than just the RVSP and the chamber size. Again, when you look at the echo, you're looking at more than just what's happening with the numbers, but kind of looking at what's happening to the right ventricle, which is usually this kind of crescent moon shaped chamber and a beautiful, strong left ventricle. But as time goes on and the progression of the right RV increases, RV pressure increases, it can lead to RV overload, kind of this change in RV structure compared to the LV and RV failure. So you're looking for obviously an enlarged right ventricular chamber, as well as an RA and PA enlargement, RV dysfunction based on multiple criteria, increased RVSP, of course, intraventricular septal flattening, and then other things that we can go through that the echo is important for. I think it's important to understand also that there's certain disease states and non-disease states that can make the echo a little bit more challenging to read. Patients with ILD and patients who are with really severe ILD may be going to transplant. They did a study looking at, what happened when you tried to read the echo. And sometimes it's very difficult to get an accurate read from the echo based on the ability to read the echo with bad lung disease. Patients who are pregnant have a very difficult time, and obesity sometimes have an inaccurate RVSP, and sometimes these patients need an invasive study to really see if there is pH or not. No matter what, if you see something on echo, you still have to get through to do an invasive test to make that diagnosis. And if there's anything for you to get out of this talk, is that the only way to diagnose pH is with an accurate right heart catheterization. Excuse me. What about the right heart catheterization? So we already talked about why it's important. It does establish the presence of pH, and it helps us kind of decide, is it group 1 versus group 2? Is it group 3 versus, not group, is there pH involved? Patients may have an echo, and you may have a CT scan that shows terrible interstitial lung disease, but you want to also get that right heart cath because now we have some therapies that are being developed and are approved for pulmonary hypertension group 3, which is hypoxemic lung disease. You also need to measure an accurate wedge pressure or left ventricular end diastolic pressure because you have to make that diagnosis between pre-transplant, pre-capillary pulmonary hypertension and post-capillary pulmonary hypertension. You're looking at, kind of adjudicating, do I have group 1, 3, 4, and sum of 5, or do I have group 2? That's the big thing you want to first get out of the way. I don't have group 2, and that can be made by the right heart cath. Then you can go through your algorithms and see what other types of PH you may have. You can do a saturation run and figure out if the patient has a congenital heart disease or ASD, BSD, or other disease states. And it helps us determine how bad the PAH may be. Do they have a cardiac index of 1.8? Do they have a cardiac index of 2.5? This becomes very important when you're talking about a patient with severe PAH and has terrible right heart dysfunction, and maybe they need pressors to be on it. When you're talking about if that patient needs to go to lung transplant, kind of what type of surgery they would get. So it's very important to understand the severity, prognosis of the disease. Always look for the underlying cause of PH, and we talked about that. Let's say you've diagnosed patients with PAH, you're like, they don't have group 1, 2, 3, 4, or 5. We think they have group 1. You want to remember the types of patients that have it, and that means going through all of the different associated risk that we talked about and patient groups that are associated with risk for PAH. Okay. The lesson 7 is treatment of PAH. So first things first, right? We have to get the diagnosis right because treatment of group 1 versus any other group is different. Treatment of group 2 is different than any other group. Group 3, we have a couple of therapies. Group 4 is definitely different, and group 5 is different between each type of category that they're in. So you first need to diagnose it correctly. Then you need to understand what the functional status is and assess and reassess risk. And actually the champion or the chief international knowledge keeper of assessing risk is on this caller. Is Dr. Ray Benza, looking at how to assess risk in PAH. What about recommending supportive measures? I mean, this is important because I think the patients have to look at things that are going to be improve their care even beyond and maybe before even focused therapy, disease-focused therapy. So we know that pulmonary rehab and supervised exercise trainings can increase and improve outcomes. It can also make improved quality of life. Psychological support is so important. When you have your first visit or the visit that you kind of definitively tell the patient they have pulmonary arterial hypertension, it is very tough. It's very hard. And you need to make sure that their family is there. And it's a very challenging conversation and fits into one of the most difficult discussions you will have with your patients. Immunizations, as with all lung and heart disease. Diuretic treatment is going to be a part of everyone's regimen. It may be really trying to keep them euvolemic, and each individual patient will be different. Oxygen. If the patient needs oxygen with walking or activity, it really is kind of related to the same type of oxygen therapy recommendations would be for other lung diseases or heart diseases. Correction of iron, that's very important. Many of these patients are iron deficient, and you want to make sure they have all the capacity they can for best oxygenation. At this time, all of the guidelines from American Heart Association, the World Symposium on pH, International Society of Heart Lung, all of them still advise about, number 1, discussing and mentoring patients about the risks of pregnancy in PAH, and that is a discussion for you, the patient's family, and high-risk OB to see if if the patient could get safely through the pregnancy, or if not. But it lines up with the one of the other very challenging conversations we have with these patients. And that includes very clear contraceptive advice. What can be used and what can't be may be different from your PH patients than it would be others. And then pre-transplant counseling. This, I believe, we talked about a lot at the World Symposium, that this is a very important discussion to have about pre-transplant. Patients are, it's very scary to hear the word refer, but to hear the word discussion and education, this should happen early on, even though it may not ever happen. It's a good idea for that, and I'm a big proponent of education and knowledge. Other adjuvant therapies that are not just goal-directed. Digoxin is really center dependent in patients who may have problems with arrhythmias later on. Oxygen, obviously, if you can find that they do have some hypoxemia, you can maybe help to prevent some of the vasoconstriction going forward. Considering, again, using it just with sleep, exercise, or altitude, and always, aiming for the target evaluation. If a patient has congenital heart disease, ASD, VSD, one of these, Eisenmenger's, they may not correct with oxygen. Diuretics, again, you have to really balance over and under diuresing someone. You don't want them to be hypotensive, but you don't want to have them go into renal failure, and you need to follow them closely because of diuresis, and making sure their lights are fine, because hypokalemia, hypophosphatemia, hypomagnesemia can lead to some types of arrhythmias that may make it difficult for them to support their cardiac output. Again, you don't want to under-diurese either, because your right heart will then be overloaded. Anticoagulation, obviously for group 4, which is chronic thromboembolic PH, you want to continue that lifelong. But for those patients who have PAH, it's on a case-by-case basis and no longer recommended for all PAH patients. This is a great paper to have. This is by Kelly Chin and her whole group at the WSPH. They were the therapeutic group meeting, and really what it entails is making sure that you understand what a high risk, a low risk, and a intermediate risk are. And so you're going to see, if you get this paper, and you can, it was in the European Respiratory Journal, and we can actually get it to this group if they need it. You don't have it. Is that the first thing is really to decide on risk. When you look at this algorithm, you're looking at both. I want you to look not just at the tree, but also this big gray box that says key points. It's very, very important. When the group made these definitions and made these criteria, they made sure we knew that this was not just a little note. These are all very important. So you first want to do initial risk assessment, which we'll talk about. And based on that risk assessment, patients will be treated either as a high risk or a non-high risk. And all of these will be based on what's gonna come in the next couple of slides. But risk assessment needs to be performed at baseline, and then every 3 or 4 months after that, using functional class, 6-minute walk, BNP as part of a risk calculator, and other things as well. But those are the most important things, at least that we have at every clinic visit almost. And then starting initial therapy is going to be based on, again, are they high risk or low risk? And what do you start with? And so once you have that done, that patient is started on therapy, and then that patient is then followed up 3 to 4 months later. Did that patient move from a higher, medium high risk to a low risk? Continue the therapy then. But if there's anything else, you want to start increasing the therapies that you see. Transplant referral should be done in patients who are high risk patients at the beginning up here, but also for intermediate who don't get better after starting therapy. Again, this just shows that a little bit more in detail, and I probably will keep going because I want to get to the questions. Vasodilator response. So patients who undergo right heart cath, if they're a patient who has either a hereditary or drugs toxins or idiopathic pulmonary arterial hypertension, will undergo a vasodilator response. And those patients who have a positive response may be a candidate for calcium channel blockers. That would be for a center to decide. If they're not responsive, then they would probably go to other goal-directed pH therapy. This is just looking at all the different types of pathways for pulmonary hypertension therapies, looking at the endothelin pathway, which is a potent vasoconstrictor, nitric oxide pathway, which we don't have enough of in pH, so it's a vasodilator, as well as prostacyclin is a vasodilator, and then activin BMP pathway, which is a newer activin signaling inhibitors, like sotatercept is a newer pathway. So first thing first, before you start treating, make sure the patient has PAH and not another type of PH. Determine the severity of disease by the risk scores, assess overall risk, and then look at how to treat the patients. Again, we're going to go to risk. I want to get to risk instead of just going through therapy right now, because I think it's important that you understand there are a few different types of pathways that you can look at. I'll go through two. The Reveal Risk Calculator, who developed and continuing develop in the development period, or continuing to develop over time, by Dr. Ray Benza and his team, looks at what are the things that can help us say what risk the patient has today for progression over the next year or 18 months. And you can see that there's multiple criteria that can be looked at and given a score. So if you have certain demographics or certain criteria, you're going to be getting those points, adding to 6, and then you end up, remember we talked about low, intermediate, and high risk. This kind of calculator has been adjudicated several times, both to show that it does kind of give us the outcomes between low, intermediate, and high risk at both 12 and also 18 months. So it's and this actually you can get on your iPhone and can be really easily adopted. Another type of score is from the European Society of Cardiology, European Respiratory Society, which is very similar, using many of the same types of prognostic criteria. Again, looking at 1-year mortality. Again, instead of just giving you a score, you kind of put them into, based on what their numbers are, into low, intermediate, and high risk, and that's for 1-year mortality. Previously, when you looked at intermediate risk, a very large group of patients were in that middle group. And so basically back about 3 or 4 years ago, the ESC, ERS said, hey, that's such a big group and they're probably different phenotypes, or they kind of do different things. And so they actually, on follow-up appointments, basically, instead of just having 3 groups, there's 4 groups, and that's an intermediate low risk and an intermediate high risk. And that kind of sets those 2 groups apart, knowing where that risk lies. So again, after treating, you want to actually reassess those patients after 3 to 4 months and repeated for the same. So after you start someone on therapy, the patient is then being assessed by the PH center every 3 or 4 months with these same criteria, and say, okay, where am I in that whole algorithm? Do I need to continue on? Am I good where I am? Do I need to add therapies? Do I need to consider referring to lung transplant? So all of these things help to tell us where to go with ongoing therapy. Some algorithm points that are important is that if the patient continues low risk, probably many of them will continue their initial therapy. There are some patients that are only on monotherapy, but most are on at least dual therapy. And transplant referral should be considered. And I think this is a point that I'd love to integrate a little bit higher into the algorithms, is that yes, transplant referral, where the patient actually goes to referral center, should be considered for high-risk patients at diagnosis, and then those who are still at intermediate high or high risk after the first follow-up after starting therapy. But I think you could put the discussion, not just the referral, but the discussion of PH, of transplant for PH patients, maybe even in here, not to scare patients, but give them knowledge. And maybe at some point, we can discuss how that can be. So we talked a little bit about what a vasodilator challenge is, and a vasodilator challenge again is really for patients with idiopathic, hereditary and drugs, toxins patients who get a right heart cath. Usually, during the right heart cath, INO or inhaled nitric oxide is given at about 40 parts per million. It's a positive test if the mean PAP increases by greater than 10 millimeters of mercury, or that patients to a mean below 40. So it has to be both greater than 10 change and also go down below 40. No decline in the cardiac index, no decline in cardiac output, and no increase in your wedge. This may suggest a response to the calcium channel blocker, and over time, it has to be followed, because you can be there at the beginning, but over months to even a year, you may need to recheck it so that you know that that patient didn't lose that reactivity. Nobody should be started on a calcium channel blocker without having a center guide them, because it could be not the right thing to do, but there is a small proportion of patients that may tolerate it. And so we want to find those patients and capture them. The problems with getting the wrong treatment. Well, group 1, if you don't find out who group 1 is and you don't know their right risk assessment, you may not give them the therapy they need, and they may need to they may have already passed the point of getting better. They may need to be referred to transplant if they've not received medicine, the right therapy. Group 2, if you give PAH medicines to pure group 2s, they may have problems with pulmonary vasodilation that could lead to more heart failure, more pulmonary edema, and they could get worse. Group 3, we keep it to right now, patients are really on inhaled therapies that are now approved, mainly because some of the oral therapies did not work for them in many studies. There was definitely worsening of disease. And so we want to make sure we know if we have group 3 before giving therapies. And group 4, we talked about, we need to make sure this is what they are, so they go to the right place and the right people. Lesson 10, appropriately, again, really timely identification and correct and appropriate diagnosis and early and effective treatment is going to help this patient. And so when you think about dyspnea in a patient, don't forget to think about PAH, and make sure you have a really good collaboration with your PH center or the person who works on PH at your site or in your city that you are very close to really get in the right place for both clinical practice as well as seeing if there's any clinical trials that are available, and having patients with a shared care type of situation. So what happened to Mrs. Number 1? Well, Mrs. Number 1's LV was 65%. She had grade 3 HFpEF, or heart failure with preserved ejection fraction. Her RV was big, but it was normal function. Her PASP was 60 and a right atrium was 10. On patient number 2, Mrs. Number 2 also had an EF of around 60, and she had a little bit of HFpEF, but not much. Her RV was humongous, 3 times normal, and she had RV dysfunction, significant RV dysfunction, and her PASP was higher, and she had 2+ tricuspid regurg. So already you're seeing the split, I hope you see from that discussion, of these patients maybe not being the same. Let's do a right heart cath on both of them. What do you think? Mrs. Patient number 1, she had an increased right atrium, right? So that's not good. Her mean PAP was 42, so that's greater than 20, so she definitely has PH. Her wedge, however, was almost 30. And remember, a normal wedge is going to be less than 12 to 15. Her cardiac index is big, it's 6.7, and she has a PVR of 1.8, and her blood pressure is high. She didn't undergo a vasodilator challenge. So that's her. What do you think she has? You can yell it out, or you don't have to. You can put it in the chat. Well, let's go to patient number 2. She had a right atrium, again, of 12, which is high. Her mean PAP was the same as Mrs. Patient number 1. However, she had a wedge that was normal and a PVR that was almost 12, and her blood pressure was slightly low. Now, this patient got a vasodilator challenge, but she probably didn't need it because she has scleroderma, and that's not one of the diagnoses we do for, remember, we are only idiopathic, drugs, toxin, and what was the other one? Oh, and drugs, toxin. So that patient didn't need one, but she got one. She was a non-responder. So final diagnosis, you might have all said it, I didn't hear anybody, but group 2, so Mrs. number 1 had really HFpEF, right? She had heart failure with preserved ejection fraction. She had group 2 pulmonary hypertension. And patient number 2 had group 1. It's kind of switched. Group 1 PAH, secondary to her scleroderma. So the clinical course for both of these patients, she got treated, Mrs. number 1 got treated for her heart failure, her HFpEF with carvedilol, Lasix, and SGL2, and then co-managed with cardiology and nephrology, and she feels better, and she's already at a class 2 heart failure. Mrs. number 2, on the other hand, got started on dual oral therapy, a PDE5 or a phosphodiesterase inhibitor 5 inhibitor plus an endothelin receptor antagonist. And over time, her symptoms have improved. And now she, though, also needed, because of recurrent and serial risk assessment, needed to go on to parenteral prostacyclins. And she's also a New York Heart Association class 2. So a little bit from the lessons, PH is common, but most often due to left heart disease or chronic lung disease, and selective pulmonary vasodilators are not proven in these patients except for group 3. You now do have inhaled vasodilators, 2 of them, that are actually approved. PAH is rare, but it's deadly, and so we want to diagnose it and identify it earlier and make sure they get to the right place and the right person. Know the clinical clues, both the symptoms and the signs. Know the limitations of echo and that it's only a test to kind of look towards where to go next, but you need a right heart cath to completely identify and diagnose and PAH. Understand the underlying disease. The etiology is very important. Some patients, you think they may be idiopathic, but with your workup, you find they may have an underlying connective tissue disease. And then treatment of PH is based on the correct diagnosis, risk assessment, functional status, and very few patients are, in number 8, vasodilator responders, but in the correct center, these patients can be treated. And then learn to differentiate group 1 from group 2, group 2 from group 3, learn to be able to know which type of pH under that umbrella that they have, and always ask for help if needed. Collaborative care is important to help early and effective treatment. And thank you so much. Again, look into, when you really want to learn more about pH, these programs go into more in depth in terms of how we treat, what these drugs do, their mechanisms. All these things are very up to date either through these kind of educational forums or on the PHA website. There's a lot of online information. So thank you so much. And I'm going to stop sharing now and see if we have some questions and discussion. Does anybody have any questions that they want to start out with?
Thank you. I have two questions. The first one is the type of pH based primarily on the hemodynamics found on right heart cath?
The right heart cath absolutely helps. Remember, I wonder if I can't go back now, but remember that slide that I had, the clinical classifications and then the actual hemodynamics. Many of the clinical classifications have the same hemodynamics, like group 1, group 3, and group 4 all have a wedge pressure that's normal, a PVR that's increased, and a cardiac output that's usually down. When you have group 2, which is your big differentiator when you're doing a right heart cath, you have that increased wedge and normal PVR. So yes, it definitely helps you get there, but it doesn't give you the exact diagnosis. You have to understand what you need to look for after you do the right heart cath. Does that, and you know what helps you there is the rest of your workup. You get a CT scan, you think it's group 1, and this guy has, ILD, or maybe they have severe COPD. So it's part of it's definitely the way to diagnose pH. And then the rest of your workup will help integrate into that, whether you have group 1 through 5. And then you had a second question.
The reason I ask is because as a rheumatologist, I see lots of patients labeled as having connective tissue disease related pH, when in fact all they have is an autoantibody and no underlying disease that we can identify clinically. And so I was curious whether the patient has type 1, whether they have an underlying connective tissue disease, how that changes the management within that group 1. Because like I said, I've seen lots of patients labeled as having connective tissue disease related, when in fact, all they have is an autoantibody with no clinical evidence of scleroderma, rheumatoid arthritis, lupus, etc.
Yeah, I have to tell you, I can't tell you the number of patients I would see, and they may have had even normal serology. So within the workup of your PAH, we always get connective to, even if there's not a sign or symptom, those patients are always, they're always worked up with at least basic serologies that may surprise you and come up to be positive. And I've had patients that actually that are normal. Their serologies were normal when I first saw them. Maybe 3 years later, all of a sudden they have a positive. So there's no question that it's important to include that in the workup, and it is in the workup when you look at. We didn't go through it too much in detail, but that is part of it. And that's why I said in many cases, make sure you know the etiology. And yes, it can. There's a lot of things in connective tissue disease that are so uncertain. It's a because it's such a they have I don't know if there's any rheumatologists in the group, but you have the hardest job of any person in medicine because it's so difficult and challenging with so many of these underlying diseases that may not even come to fruition. In terms of the PAH, if the patient doesn't have lung disease issues, much of the therapies are going to be the same. If the patient has scleroderma with ILD, with PAH, then the therapy may change. If they have PAH and they have maybe RA or another connected, maybe lupus, much of the therapies are going to be a combination between you and the rheumatologist treating. So it's a really good point you put there. So thank you. I think we have, do we have time for one more question? I think we're at time. We have
Yeah. So it's almost 1 p.m. We'll quickly have one more question and then we'll wrap up. Dr. Casabo?
Oh, I think there's one in the
Thank you.
chat.
Thank you, Park. If you could briefly just comment on, since this was patient 1 was group 2, why did they choose beta blockade rather than MRA versus RNE? Or thank you.
This case might have been a little older, so that might be it. This case may have been a little bit older before that part came out. So that,
Dr. Pence.
and I think there's one more.
Uh-huh.
There's a question in the chat we don't want to forget about someone. New insights, rules of thumb regarding pH associated with obesity hypoventilation. I think the idea that patients with bad OSA hypoventilation they're difficult to treat. The one thing that really needs to happen is they need to really, just as the old guidelines said, the new guidelines continue, is that treating OSA is very important before looking into seeing if this patient has any underlying other PAH. So really getting that under control, retesting them after you get them on CPAP or their correct, PAP therapy is really important. So that continues to be the same. When you get to OHS and obesity hypoventilation syndrome, that does get difficult, but again, it's still treating that disease first.
Dr. Benza, I see you unmuted yourself if you wanted to share your thoughts or ask a question.
Yes, Debbie, thanks so much for that great lecture. Really appreciate it. In terms of the World Symposium's risk allocation for using medications, just curious about your own personal opinion about what I feel is an oversimplification of the first step of risk stratification as marking someone as high risk or not high risk. It essentially tells us that there is not one very low risk patient that can presently be treated with monotherapy. And I'm curious about your opinion regarding that.
That is such a good point. Ray, thank you for bringing it up. And it is very difficult because I think we all have patients that we feel are at that point, or they may not be able to tolerate one or the other drug. For that reason, many patients, I do start first with one therapy, make sure they tolerate it, and then add it on. It is something that's a nuance that I don't know if how that kind of wordage or language will guide people just going into pH and taking that for the word of pH gods. But I think that there is a nuance in knowing your patient and knowing where they stand in terms of their risk assessment, but also in terms of what they could tolerate in terms of their drug, their tolerance to more than one drug at a time, or which drug they would go on. So it's a really good point. It's a great point.
Thank you so much, Dr. Levine. And thank you so much, everyone, for joining us today. It was a great talk. We really enjoyed it. And hopefully we can have you next time in person. With this, we wrap up the grand rounds for today. Happy holidays, everyone. We'll see you guys next year in January with first session of grand rounds. Thank you so much, Dr. Levine.
Oh, thank you, guys. Have a great vacation. Thanks, Barb and Trish. Thanks, Dr. Benza. Bye.
Thank you all. Thank you, Dr. Levine.